Yeah, it's normal now. It's better. It's
Okay.
good.
So Sanjay, you will give commentary while doing, this robo preparation.
Okay, so this is actually the cassette which is disposable for each case that we fix on the arm of robo, and this is the basic instrument by which robo is doing movement of PTCA wire, balloon, stent, even there is side track also if you want to keep wire for the support.
Auxiliary track.
Auxiliary track. So now we are fixing this cassette in the robotic arm. Okay. And here everything comes what is going on. It is testing the cassette. So robo has tested, and we have to tilt robo like this before we attach it to the guiding catheter, PTCA wire, and everything. So now I am introducing guiding catheter up to ascending aorta, and I will load it with PTCA wire. Then everything will be done by Tejas bhai from robot. So again it is 5-in-6, 5 French multi-purpose, and JR 3.5 guiding catheter.
But when I am
Okay, so hello.
there is one more mic we need for the
Vaguely.
guest. What are you guys doing?
PTCA wire. मैं balloon load कर देऊँ छे PTCA wire balloon. અને 2x12 PTCA balloon. BMW. So we part guiding catheter in ascending aorta, and now we load this cassette with PTCA wire, PTCA balloon. First we are fixing this guiding catheter to robo. So here. Video kya hai yaar? Nobody is here.
Samir, can you guys see properly?
No,
No, I think Sanjay bhai is right. If they can go on the other side to show the opposite end of where they're showing right now,
come here.
that'll be better.
Come on this side. Come on
There
this
we go.
side.
Yeah, that should improve our
So
visibility.
this is a cassette which I open, and I'm just fixing guiding catheter in this slot. Here. This is a sleeve. Okay. Now PTCA wire.
So you can see the slot for the TUI and the
Yeah.
guide nicely at the tip of the cassette. And now,
Balloon 2x10. Okay, 12.
now there are two merging lanes that will go into the TUI.
So now this is a PTCA wire. Okay. Wait, cost, please.
Which wire we have taken, Sanjay?
BMW.
BMW, okay.
So it is just to hold. Now we are introducing PTCA balloon over this wire.
The key to this is having a team that knows how to set all this up efficiently.
Okay, now I am putting this PTCA balloon in its slot, PTCA balloon slot, and PTCA wire slot is this. Now we are ready to go.
Now, just focus the camera here with me.
Now go there. Okay. Now go there.
So that's the cockpit, right?
Yeah.
Yes. Here, enable all, and these ROR rotate on retract. And we are all set now. Can you hear me, Samir?
Yeah, we could again. The voice is starting to degrade, but it's not as bad as
No,
it was
then
previously.
why are these people doing this? The voice is not good, that is what they say. Babu?
Sir, you speak.
It
sir.
sounds like the pilot from the cockpit.
Yes, yes, yes.
Can you take my?
Let me
Maru,
take the mic.
TJ, sounds like robot.
There's me.
Jago.
Boss has been
Maru
changed
No,
to
no.
Robo.
Just remove this.
Give me the mic, please. Now that you are, somebody should hold the mic here properly. Parag. What? No problem. Can you hear me now?
Yeah, much
Yes,
clear,
yes.
normal now.
Normal. This is coming out. So I will be now working. If you have, any problem with my voice, just let me know.
Absolutely.
I am now cannulating the guide.
Can we show the fluoro on one side of the screen?
Yeah, just show the fluoro on one side. Can you see the fluoro now?
Absolutely,
Yes,
yeah. Now
yes.
it's great, yeah.
Inject. It is hooking the left. Inject.
You can hear the clicking sound of the robot.
Inject. Little bit. I will come up and go down. Inject. We are near. Inject. It's a wrong cusp.
Yeah, still in the left cusp, yeah.
It's going, it has a tendency to go to the wrong cusp.
Yeah, it likes to go to the left cusp over and over.
Now,
Now it's good.
I am
Yes.
almost there.
Now you're
Inject.
in.
Yes, engaged.
That's in.
Okay. Record. Okay, I am just changing. There is some small issue. I am going to the small screen then. You can see the, okay.
Yeah, we see the fluoro and we see you maneuvering.
My wire is now going in.
So that is a straight advancement, right?
Yeah.
And then now you'll be able to torque.
Here there is a lesion. So I am using rotate and retract software.
Very
And I
good.
mean,
It's a nice dive.
inject. Again I am using rotate and retract. Inject. Inject. We can see the length. We have to use anyway 2 stents. Okay. Inject. Looks good.
Yep, looks very
I am
nice.
going to the bigger branch. Again rotate and retract.
Yes.
Okay. There you are. Record.
Fine, fine.
Fine. So balloon, I am using the turbo, function just to slide my balloon. You're very fast there. Inject. From here we should start. It's not a critical area. Anyways, okay. Go on dilating. 6, 8. Record, deflate, 6, 8. Deflate, 6, 8.
In robotics, any chance of melon seeding or like that movement or?
As of now, we have not faced all those problems, but it is too premature to give a very bold statement. But yes, it is working. Go up, 6, 8. Deflate,
No, barabar.
6, 8. I think this is a critical lesion there.
Yep. There.
10,
you got it,
record,
yep.
deflate. Let us check it now. I am record. Is that okay?
Looks like it's pre-dilated, yep.
So, we can cover everything with one stent? You think so?
No,
I think if you go normal to normal, you need two anyway.
stent.
Two stents.
Yeah.
Two stent, yeah.
Two stents.
So the first stent, we are going to a very normal segment. So we can take
Parikar se wala.
Do you still have that Pro Nova German stent?
no,
Tejas?
no.
We don't use.
That was a long stent.
The long, Giants Expedition, we have 48 millimeter
48,
length
yes.
available.
We have one Indian made stand is 60 mm.
Yeah.
Yeah, this was also coming in
Sanjay?
60, I
Yes,
remember.
remove-
Length and diameter?
3?
I think so. We can take
38.
3 by
38?
38.
Yes.
Yeah. Give me 3 by 38 synergy or the Promus Premier. 3 by 38.
Sir, balloon remove.
Yeah, we have to remove the balloon. That's right. I forgot. Okay?
Okay.
That's it.
Now, they're using manual injections of contrast.
Now-
You can use an assist
Come here.
device and
You
add more
you
automation
can go
to the
there,
system.
how they load the stent. Yes.
So-
3 by 38 Promus Premier.
Weight goes.
Sanjay, somebody should you have a mic, right?
Yes.
Samir, can you guys hear Sanjay's voice clearly?
Yes, we
because
do.
we
Yeah,
have changed the
we are
mic.
loading-
No, yes, we do now, yeah.
We are loading this stent over the wire, just like a balloon.
So how far do you have to advance the balloon or the stent? All the
Yeah.
way to the guide tip
Yeah,
or
up to these two markers.
up to the
almost, yeah,
to the marker? Okay,
ascending aorta.
excellent.
Again, we are fixing balloon and wire in their respective tracks.
Yep.
And is ready.
Yeah, so come over here now.
Go there.
Now again enable all and we are set right. I am going in. I will just pull my wire little back. It is too deep in. And now okay. Inject.
Yes.
This looks good.
Little push.
Little forward.
Push.
Yes.
Okay. Inject. Normal segment now?
Thomas.
Little back.
Okay,
Yeah.
I think that might be
Inject.
good. Yep, that's
Yeah,
probably
good.
going to be
Okay,
a.
I'm going up.
go.
Yes, it's all right.
12. Hey, it has come out.
No, he just took a breath, I think.
Yeah, that's a problem. Anyways,
but
we'll
it
see.
is there.
I
Yeah.
think we
I
have
think you'll be okay.
covered the segment.
You had
yes.
10 millimeters to play with.
Yeah.
Tejas, Rajiv here. Do you use the stent, the robot to measure lesion length? I know you
Yeah,
can do
yeah.
that.
Yeah, sometimes. Sometimes, yes. We can go a little back and give a high pressure here. Give a high pressure here. 15, 17.
17, 18.
Deflate.
Okay.
બહુ એમને કે ઊંડા શ્વાસ બહુ ના લે યાર.
Length proximal, we have to take proximal length.
So
Okay, take cine.
okay.
Yes.
Distally probably it is
Spasm.
overstretched and spasm. Maybe there is some D. We will work on it. No problem. Here I think we can take 20 millimeter.
20,
Yes.
no, 28.
23 or 28, somewhere
28,
around it. Yeah.
28.
The 28 will be too long, Sanjay.
23.
24
Yeah, 24 might
23,
be
24.
good.
maybe.
28.
28 will be.
No.
You think it's little
Yeah,
long,
yeah.
Sanjay?
Just after ostium.
Now inject and see.
Chal, see.
I agree. 20
28 would be comfortable.
comfortable.
Then
Okay.
you will not have to split hair.
Okay, give again 3 by 28. I am removing the balloon now.
Okay, okay.
If need be, I can use a small stent and go through the stent and fix distal area. Let us see.
Or do we want to give nitro or something?
Yeah, that Sanjay will
Yeah.
be giving. Samir, one observation, consistently I am seeing this type of so-called distal spasm,
बताओ महसूस.
90% of time it is a dissection.
Nitro.
I don't know what is your view.
Yeah.
Are you planning to do OCT?
No.
Yeah, I think,
No.
it depends on
Wire pull
Where
back.
I'm remove.
on the landing zone. But you're right. I mean, if you landed in the plaque, it's a good chance it'll be a tear.
As well as if the stent is implanted distally in a curve, it may cause dissection.
Back pleat. And meanwhile stent up.
Most often.
Any question from the audience? I think we need to encourage the audience.
Yes.
Questions. There's a microphone in the front. Is anyone have question? Please come down and ask Dr. TJ Patel.
There are mics capped on the stairs also of the auditorium.
Hello.
Yes,
Sir,
please.
Namaste. I am Dr. Iftikhar Alam from Bangladesh.
Yes.
What is the additional benefit of robotic technique over traditional technique?
We have to prove the benefit yet. Any new technique or technology coming, in the field will have to go through this testing time. We are not claiming high, but one thing is sure that this is going to be the way of life in future. We have to abstract benefit. When angioplasty, was introduced by Andreas Grunzig, the same question was asked by cardiac surgeons. What are you guys doing? Even for stent and for everything. So for these also, we are trying to find some good benefits apart from the operator benefit, that is radiation. We are trying to find, and they are coming out with incorporating lot of artificial intelligence now, into this robo, and this is rotate on retract is one software. There are some 6 new software coming by the end of second quarter this year, and they all will be incorporated, and the life will become more and more easy.
I think you're right. this is really, really brand new technology. There's definitely a lot of improvement, and how the benefits to the intervention community is still need to collect a lot of data. But I'm sure in the next generation,
Looks good.
future generations, you must show some benefit.
It is,
I mean,
it is
radiation
moving.
is really bad to everybody.
Sanjay?
So I think
Okay,
we need to
guiding
keep an
little
open
out.
mind for that.
Guide,
Okay, I will,
go.
I'm going up. Little scout.
Give, go.
Fine. Yeah.
12, 14, 15,
15.
deflate.
There is also a 3O stent.
Yeah,
Yeah,
this is
3O.
3O.
Look good size there.
It's pretty easy to imagine how the robot should get access better than
That's
us as well,
right.
right? I mean, you put an
Yeah,
imaging
Raju.
probe and teach it how to get access and do a diagnostic and import the CTA, and
Go up
then
here.
you are out of a job tack.
18.
By then he might have been retired.
Tack will
Deflate.
never retire.
That's true.
Well, 30 years ago, they told us we'd be out of a job too with CT scanners, and we're still waiting for that.
Inject.
Fine.
Oh,
Distal is also
distal
good.
spasm is gone with nitro. Everything looks good. Any comment on the result?
Looks nice. I think there is some positive, I mean some proximal angle there after the stent
That's
into
right.
the ostium. But I think it'll be stable. I think once you pull the wire, that might go away.
Yeah. Go to AP cranial.
There is any lag between you manipulate outside and inside, time delay or
No,
Zero.
zero.
Even that time lag was not found in our distant robotic stenting. It was
Okay.
80 to 100 Mbps speed, you know.
Yeah, it was
It's
53 millisecond lag
Oh,
between
yeah.
20 miles.
Oh.
The mean lag was 53 milliseconds.
Okay, go to
that was
LAO.
great.
Hello.
I am cannulating. Okay. I am removing the wire. Okay. Go to LAO cranial. Last view.
We did a whole series of experiments on lag time with the robot at our institution, and anything less than 100
Great.
milliseconds is barely perceptible
And
to us.
I am now removing the guide with the knob, counterclock rotation and pull back. This is how we finish this robo case. So, any questions regarding this, I am very willing to answer. This is a new technology, and we have to patiently, try to work on it. One thing is sure that wherever, in whichever field, whether it is a medical field or a non-medical field, wherever robo has been introduced, it has made its impact at most of the places, okay? And we are waiting, for incorporation of more and more artificial intelligence. Ultimately, I personally feel that robo
SCT.
with a good artificial intelligence, as Rajiv told, that if you can puncture the radial with robo and you have CT available from radial or femoral up to the coronary, and if CT image is being incorporated in it, ultimately a lot can be done. And the difference between the results of a very experienced operator vis-a-vis a medium experienced operator vis-a-vis a very new operator will be reduced, and there will be more and more homogeneity as far as the results are concerned, and that is what we want actually. We will be shifting to the south lab, where there is one very interesting case of arterial lusoria. So by that time, the panel, I will take another 1 minute, and by that time, the panel, can continue discussing whatever, and I will be there ready. Okay? Thank you.
Thank you. That was a
Thank you
very
much.
nice case. Awesome case. So I think the next wave of robotics is going to be more based on precision and patient benefit. So far, all that we can brag about is the operator benefit. Tejas was able to sit, not wear lead, have very good radiation protection with thick glass of, leaded glass. And all that is just benefiting the operator. I think the next, with incorporation of haptics and some artificial intelligence, we'll see some robotic, benefit to the patient, himself or herself. Any comments from the panel?
What about the zero gravity lead apron versus this robotic?
Yeah, zero gravity lead is also one way of removing the compression on your spine. It does have a learning curve, and for difficult cases, it actually, most operators tend to break away and wear the regular lead when they have to go to battle, so to say. So it's a good, suspended lead system for doing the average case. We use it, and it's nice. We have it at one of the VA hospitals.
Raji, what cases you don't want to do robotic at this moment?
Yes, I think that's a great question. With a current generation device, any two-stent bifurcation you wouldn't do. There is with the one that Tejas was showing, there is another track you can park a second catheter, but it's not robotically controllable. So anything where you're doing simultaneous, you want to avoid the robot. I think these are relatively minor things that can be overcome in the future generation of devices. And I think the people that want to use this now are the ones that believe that